Welcome to the Explainer. Let's just dive right into it. Today we're doing a high-yield systems-based rapid review of hantavirus. And listen, whether you're prepping for the USMLE or NEET PG, this pathogen is an absolute favorite in test stems. It comes up all the time. So let's get focused, cut the fluff, and lock down exactly what you need to know to crush those questions.
We're going to logically build your understanding by following a strict roadmap today. We'll start with virology and genome structure, then move into pathogenesis and vascular leakage. Next up, clinical syndromes, comparing RFFRS and HCPS, followed by diagnostic modalities, and finally antiviral treatments and pharmacology.
All right, jumping right into Section 1, virology and genome structure.
Okay, check out this spherical enveloped virus. You see those prominent glycoprotein spikes on the surface? And right inside, that very distinct ribonucleocapsid structure? Burn this visual into your brain, because understanding its physical structure is literally the foundation for grasping exactly how this virus operates, and more importantly, how it survives.
Now let's talk high-yield buzzwords. When you see a question, look for these specific triggers. Hantavirus belongs to the order Bunyavirales. It's a negative-sense single-stranded RNA virus. And here's a massive detail. It is uniquely enveloped via the host's Golgi complex, not the cell membrane. And the absolute classic transmission clue in any clinical vignette? Continuous shedding in rodent excrement. If the stem mentions mouse droppings, you immediately think hantavirus.
It also has a really interesting tri-segmented genome. You absolutely have to memorize these three segments. The S segment synthesizes the nucleocapsid. The M segment encodes the GN and GC envelope glycoproteins, those spikes we just talked about. And the L segment, that encodes the crucial RNA-dependent RNA polymerase. If they throw a genetics question at you about this virus, I guarantee it's going to target these exact segments.
Let's keep moving to Section 2, pathogenesis and vascular leakage. So how does it actually break into the cell? Here are the crucial viral entry steps. Step 1, attachment to beta-3 integrins, and it does this using those viral glycoproteins GN and GC. Step 2, endocytosis via clathrin-coated pits. Step 3, uncoding happens right inside the endolysosome. And Step 4, replication kicks off, utilizing that L segment encoded RDRP. Boom, it's in.
Following that entry, the viral mRNA translates on free ribosomes and the rough ER, and then, here's the kicker, it assembles at the Golgi complex. Seriously, do not forget that Golgi assembly. It is a highly testable, very unique step in its life cycle.
Now let's look at the immunological mechanisms leading to endothelial barrier breakdown. And you know the crazy part here is that infected endothelial cells don't just die directly from the virus. Instead, they trigger this massive, overwhelming immune response that leads straight to vascular leakage. So yeah, it's actually the body's own exaggerated defense system that causes the most critical damage. To get specific on the pathogenesis mechanism, the virus primarily targets macrophages and endothelial cells. This kicks off an immune cascade that activates CD8-positive T cells and NK cells. Now, here is a highly specific point for your exams. PTX3 drives neutrophil notosis. And the ultimate effector that causes all that shock and edema? Massive TNF alpha release causing vascular leakage. That is your final answer for the mechanism of shock here.
Okay, Section 3, clinical syndromes, specifically comparing HFRS versus HCPS.
For the boards, you absolutely must be able to contrast these two side by side. On one hand, we have HFRS. This predominantly affects the kidneys. It's mostly seen in Asia and Europe and carries a 1 to 15% mortality rate. The classic causative strains, Hantan and Sol. On the other hand, we have HCPS. This one targets the lungs, is found in the Americas, and guys, it carries a massive 40 to 60% mortality. For HCPS, you're looking at the Andes and Sin Nombre strains. Geographic location and the target organ are your ultimate diagnostic clues on a test stent.
So let's say a case study presents a patient moving strictly through these 5 clinical phases, starting febrile, then getting hypotensive, followed by an oliguric phase, then polyuric, and finally convalescent. If you see that exact progression, you need to immediately suspect HFRS. That 5-phase journey is the absolute clinical hallmark of the renal variant.
Now for HCPS, the pulmonary syndrome, it moves frighteningly fast. It rapidly progresses from a simple prodromal phase of just malaise, fever, and maybe some GI distress, straight into a severe cardiopulmonary phase. We're talking acute pulmonary edema and severe hypoxia. This right here is exactly where that scary 40 to 60% mortality risk hits. And get this, Even if they survive and make it to the convalescent phase, their dyspnea can persist for up to 2 full years.
Moving on to Section 4, Diagnostic Modalities.
What's in our diagnostic toolkit? Well, a patient history of rodent exposure combined with acute thrombocytopenia on a CBC should be a huge red flag. That combo triggers immediate action. You're going to want to order an IgM or IgG serology via ELISA, and of course, a real-time RT-PCR. But remember this crucial caveat, that molecular PCR is really only effective during the acute viremic phase.
Finally, let's hit Section 5, Antiviral Treatments and Pharmacology.
Let's look at the mechanism of action inside the host cell for our first-line pharmacological defense, ribavirin. As you can see, it directly disrupts the viral replication cycle by essentially integrating itself and blocking normal nucleotide synthesis.
You really need to lock in this specific ribavirin MOA. It's a purine nucleoside analog, and it works by competitively inhibiting IMPDH. Why does that matter? Because it completely depletes de novo GTP production. It literally starves the virus of its building blocks, which in turn induces lethal RNA mutationism. Make sure you understand that step-by-step mechanism cold.
Now, what about other high-yield antivirals? For matching questions, keep these in your back pocket. Favipiravir, also known as T705, selectively inhibits the RDRP. Then you have ETAR, which lowers GTP but without causing mutations. And vandatanib? This one is super fascinating. It's actually a host-targeting antiviral that specifically inhibits VEGFR2 kinase. By doing that, it stops VE cadherin degradation, essentially plugging the holes to stop vascular leakage right at the endothelial barrier.
Aside from small molecules, we are also looking at some seriously cutting-edge therapies, like RNA interference. This diagram shows exactly how it utilizes post-transcriptional gene silencing to directly target and take out the viral mRNA.
Breaking down this siRNA-based therapy, it uses post-transcriptional gene silencing to target the specific viral S, M, or L mRNA segments we talked about earlier. From there, the RISC complex comes in and just degrades the viral mRNA. It sounds perfect, right? Well, there is a catch. The major clinical limitation holding it back right now is in vivo biological stability and just figuring out how to deliver it effectively in the human body.
And that wraps up our explainer on hantavirus. But it does leave us with a really critical thought for the future. With RNA and small molecule inhibitors advancing as fast as they are, could we soon see a definitive cure? Or will the virus's highly error-prone replication keep it perpetually one step ahead of our pharmacology? It's a crazy arms race. Keep studying, definitely lock down these high-yield concepts, and I'll catch you in the next explainer.